Jaundice due to cancerous obstruction of lower bile duct can be due to different causes. This video explores this. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about has been told there's a mass near the pancreas causing jaundice, you're in the right place. I know this diagnosis can feel overwhelming. The uncertainty about exactly which cancer it is, and why that even matters, adds to the worry. The ampulla of Vater is a small but critical junction deep inside your abdomen, where your common bile duct and pancreatic duct join together and empty into the small intestine. When cancer develops in this region, it can arise from 4 different places: the ampulla itself, the head of the pancreas, the distal bile duct, or the duodenum, which is the first part of your small intestine. Here's why this matters to you. These tumors often present in exactly the same way, with painless jaundice yellowing of the skin and eyes. That's about 50% of pancreatic cancer patients, and approximately 50% of ampullary cancer patients presenting with this symptom. Because they're all crowded into the same small anatomical space, they cause similar problems. But they're not the same disease, and that difference determines your prognosis and treatment options. Here's the reality that catches many patients off guard. Even with modern imaging, CT scans, MRI, endoscopy, doctors often cannot definitively tell which type of periampullary cancer you have until after surgical resection and complete examination of the tissue. The research is clear on this. Among patients who have a mass in the head of the pancreas or malignant bile duct obstruction near the distal common bile duct, differentiating pancreatic carcinoma from other periampullary malignancies arising in the ampulla, duodenum, or bile duct is challenging. You might have an excellent CT scan showing a tumor, but the radiologist writes periampullary mass rather than specifying the exact origin. This isn't because they're being vague. It's because these tumors sit so close together that until a surgeon removes the specimen and a pathologist examines it under the microscope, the true tissue of origin may remain uncertain. The imaging modality called endoscopic ultrasound with tissue sampling has sensitivity and specificity above 90% for diagnosing pancreatic cancer, but even this may not distinguish between all periampullary tumor types preoperatively. You might hear your doctor mention the double duct sign on imaging. This refers to dilation of both the pancreatic duct and the common bile duct, visible on CT or MRI scans. Now here's where it gets interesting. This sign is present in approximately 62 to 77% of cases of pancreatic cancer, but approximately 50% of ampullary carcinomas also have a double duct sign. What does this mean for you? The double duct sign tells your doctor there's definitely a problem causing obstruction, but it doesn't tell them which cancer. You can think of it like a smoke alarm going off. It alerts you to danger, but doesn't specify whether it's a kitchen fire or electrical issue. The imaging modalities, whether CT-MRI with MRCP or ERCP, are excellent at showing that ducts are blocked, but they all face the same limitation when trying to pinpoint the tumor's exact origin before surgery. This is the critical question. If they all present with jaundice and all need the same surgery, a Whipple procedure or pancreatic duodenectomy, why does it matter which one you have? The answer is prognosis. Ampullary carcinoma has significantly better survival outcomes than pancreatic cancer. While pancreatic cancer 5-year survival rates for resected disease hover around 20.5% with optimal treatment, patients with ampullary cancer who undergo complete resection have considerably better long-term outcomes. The difference isn't small. We're talking about the potential for years of additional life. Now what about bile duct cancer, also called cholangiocarcinoma? This falls somewhere in between. The prognosis depends heavily on whether surgeons can achieve an R0 resection. That means tumor-free margins with no cancer cells at the edge of what's removed. If you're wondering why this difference exists, it comes down to tumor biology. Ampullary cancers tend to cause symptoms earlier because they obstruct the bile and pancreatic ducts when they're still relatively small and localized. Pancreatic cancer, by contrast, is biologically more aggressive. It spreads earlier through lymph nodes and blood vessels. For those supporting loved ones, when you hear periampullary tumor, it's completely reasonable to feel anxious about the uncertainty. But remember that ampullary origin is associated with better outcomes, so the wait for final pathology after surgery can actually bring better news than initially feared. The primary treatment for all resectable periampullary tumors is the same operation: pancreatic duodenectomy, commonly called a Whipple procedure. This involves removal of the pancreatic head, duodenum, first 15 centimeters of jejunum, common bile duct, and gallbladder. Modern series show perioperative mortality of less than 3% at high-volume centers, a dramatic improvement from over 15% in the 1970s. If your doctor mentions needing surgery at a specialized hepatobiliary center, this is why. Hospital and surgeon volumes significantly impact outcomes. But here's what differs after surgery. The adjuvant treatment recommendations may vary based on final pathology. Pancreatic cancer typically requires combination chemotherapy regimens. The 5-year overall survival rate with neoadjuvant therapy, that's chemotherapy before surgery, was 20.5% compared with 6.5% with surgery followed by adjuvant therapy in major trials. For ampullary cancer treatment strategies are tailored based on histologic subtype. There are intestinal type and pancreatobiliary type ampullary cancers, and these respond differently to therapy. So here's your bottom line. Let's talk about the 3 categories of action you can take. First, if you've been diagnosed with a periampullary mass, write down these specific questions for your surgical consultation. Based on imaging, can you estimate which tissue the tumor likely arises from? What is your institution's surgical volume for Whipple procedures per year? Higher volume, ideally 15 to 20 or more annually, correlates with better outcomes. Will final determination of tumor origin require complete surgical pathology? How does the potential origin affect my prognosis? Second, seek consultation at a high-volume hepatobiliary center if you're not already there. The meta-analysis data is unambiguous. There is a significant association between surgeon and hospital volume and post-operative mortality and survival after pancreatic cancer surgery. Third, if jaundice is present, discuss biliary drainage timing with your team. Not all patients require preoperative stent placement, and stents can cause artifact on CT imaging that masks the lesion. The timing matters. Stent placement should be avoided in patients who have not yet undergone CT, because trauma from stent insertion may induce inflammatory changes indistinguishable from tumor. Family history and genetic risk. Between 4 and 20% of patients with pancreatic cancer have germline mutations in known cancer predisposition genes. If you have multiple family members with pancreatic, breast, ovarian, or colorectal cancer, mention this. Genetic testing may be indicated and could influence treatment decisions, particularly regarding targeted therapies. Neoadjuvant versus upfront surgery approach. For borderline resectable tumors, chemotherapy before surgery may improve outcomes. The PREOPANC trial showed median survival of 15.7 months with neoadjuvant therapy versus 14.3 months with surgery first, and 5-year survival nearly tripled from 6.5% to 20.5%. Biliary decompression approach. If you present with obstructive jaundice, ask whether endoscopic stenting or percutaneous drainage is recommended, and understand that delivery of neoadjuvant therapy necessitates durable biliary decompression for up to 6 months. When to seek immediate medical attention. Worsening jaundice with fever and chills. This suggests cholangitis, infection of the bile ducts, which requires urgent treatment. Cholangitis, developed in 39% of patients in one series following stent placement. Sudden severe abdominal pain. Could indicate pancreatitis or other acute complications. Persistent vomiting. May suggest gastric outlet obstruction, a potential complication requiring intervention. Weight loss exceeding 10% of body weight. Warrants aggressive nutritional support and reevaluation. Let me quickly recap. Periampullary tumors. Cancers arising near where your bile and pancreatic ducts meet can originate from different tissues, and distinguishing the exact source often requires surgical pathology, not just scans. This distinction profoundly affects your prognosis with ampullary cancer, offering significantly better survival than pancreatic cancer. Your next step: seek care at a high-volume center and prepare specific questions about tumor origin, surgical approach, and whether neoadjuvant therapy might benefit you. I've outlined several reputable resources here which you may find valuable for further information on this topic. National Comprehensive Cancer Network (NCCN) Guidelines for Pancreatic Adenocarcinoma. American Society of Clinical Oncology ASCO Clinical Practice Guidelines. Up to date. Epidemiology, clinical presentation, diagnosis, and staging of ampullary carcinoma. Johns Hopkins Medicine Pancreatic Cancer Center resources on periampullary tumors. All links are available in the description below. Thank you for watching.